Okay, so now you probably see the slides. So as Sibel said that this is a comparison study with adolescents and therapists and on the alliance, but it's also a part of a larger study that we're doing overall on the effectiveness and predictors of treatment outcome in adolescent psychotherapy. And this is my PhD study, and we have already published a few papers on the effectiveness and the overall on the predictors of outcome and dropout. And today we'll be discussing the third paper that's about the alliance. So I won't go much on the details, but as Sibel said, that we do know that alliance is a very important common factor related to the positive treatment outcome, and it seems that it is also with adolescents as important as it is with adults, and that weak alliance also predicts the premature termination of treatment, not just the outcome. But we don't know so far, at least, that not that much research has been going on is how the alliance developments and improves like over the treatments, or does it actually improve? What happens? Does it change when the treatment goes on? And it's not also very clear that alliance rated by who and when, like at what time point at the treatment would be the best predictor of treatment outcome. So these were kind of the background questions that we had when we started doing this study. So the aim was actually to see if adolescents and therapists rate the alliance in the same way, and if some change in the alliance happens over the treatment, because mostly like previous research, especially on adolescents, have assessed like alliance is something that's assessed like in the very beginning or after like the few sessions in treatment, but not really like assessed during the treatment at very many time points. So we don't know that much what happens like during the treatment with alliance. And then we tried to see like which rating or combination of ratings would predict the treatment outcome the best. So would it be the adolescent or the therapist, or some combination of this? And we had 58 adolescents. This is like a long-term follow-up study. We actually have followed the adolescents there, and all were kind of assessed to a long treatment. So minimum a year, maximum 3 years, and we followed them during the whole treatment period. And then we also actually have a 5-year follow-up. But my PhD study is about the first year. So also this alliance study is only considering the first year in the treatment. And the adolescents, when the treatment began, was from 13 to 15, so they're quite young adolescents, and we had a large variety of different treatments. That's one part maybe that we can discuss together, and Antonella has more stuff or saying something about like the different treatment modalities. Our first study did look like compare psychotherapy based on the verbal interaction with the art and occupational therapies, or therapies that have also something else than just verbal based, but there was no difference actually in the outcome. So for this study on the alliance, we have combined these both groups, so there's no comparison group in this study. We had some outcome measures, Beck depression inventory, and the main outcome measure is the core OM, and then the working alliance. We had the long working alliance inventory. You have to keep in mind that this study is conducted in Finland, so we don't have as many measures available as there might be in English, and also that we started the study 10 years ago. So maybe now if I would set a new study on treatment outcome or the alliance with adolescents, I might choose something differently, but I still think that even the long version of the VI is a pretty good measure with adolescents. But well, let's go directly to the main results. That's kind of the frame for the study. But what we did notice was that there wasn't significant change in the alliance during the treatment. There was like a small positive trend, but not really big changes. We measured them at the baseline at 3 months, 6 months, and after one year, and there wasn't really not the patients nor did the therapist evaluate that the alliance would change a lot. Overall, the therapist rated the alliance higher than the adolescents, but the change wasn't significant there either. But what we did notice, like if you look at the means in the alliance, it seemed like, oh, they go pretty well together, that the adolescents and the therapists, the means at each time point do not differ significantly. But when you started to look at the pairs, like adolescent and therapist pairs, the correlations were very weak. So we noticed that actually adolescents and therapists rated the alliance very differently, and they did not correlate together. And when you think like which informant was more predictive in our study, it seemed that it was the patient. So the patient, if they rated the alliance weak at the baseline and at the three-month assessment point, those were the points that we used as predictors, because clinically we thought that if you try to predict kind of the outcome in 12 months, it wouldn't be very useful to look at the alliance at the same 12-month point, because there wouldn't be like any prediction actually on that point, but just looking at how did it go. So we looked only at the first two points assessment points for alliance. But even if looked at the baseline or at three months, it seemed that if adolescents rated the alliance poor, then the outcome was also poorer. But the therapist rating was not related to the treatment outcome actually at all. So that wasn't very, that was actually a bit surprising, not according like that. We hypothesized something else, so we kind of expected that there wouldn't be such a difference, or that even that the therapist rating might be more predictive than the adolescent rating, but it wasn't so. And also we looked at the discrepancy between the patient and the therapist, and it seemed that the higher the discrepancy was in the ratings at the baseline, the worse was the outcome. So especially if the adolescent rated the alliance to be weak, but the therapist rated it to be high, then the outcome was quite bad, or it might even got so that symptoms got worse during the treatment. And also the weak alliance was related to treatment dropout, but especially when the alliance got worse, if the adolescent thought that the alliance is getting worse in the first three months, then the risk of dropout was 4.5 times higher than if the alliance was stable or improved. So what we did conclude was actually that the adolescent rated alliance seems to predict the treatment outcome better than the therapist rated alliance. So what as clinicians that tells us is that we should frequently use assessment of therapeutic relationship within the therapy. So do not rely on your own thinking that the alliance is good with the patients. Therapists weren't that good on rating the alliance, so we should use the assessments, and also pay special attention if the adolescent feels that the alliance is getting weaker, or that there is a larger discrepancy between my rating and the patient's rating. So it would be helpful to use the tools, assessment tools, and then to see if we rate it similarly, and to discuss with the patient in order to kind of help them to improve the alliance and also stay in treatment. So that's our paper and study in brief.
Thank you so much. It has a lot of clinical and research implications. It stimulates also a lot of points for discussion. Before that, I'm gonna also invite Antonella to discuss her work with us, to introduce her work. And I think it ties in quite well, like you said, Vera. Antonella is going to discuss how alliance differs in different types of treatments and how it changes over time. So these two studies are quite complementary. So, Antonella, would you like to share your work with us?
Yeah, sure. Well, I didn't prepare any formal presentation, but yeah, I'm happy to talk about it. So what we explored in the study that I'm presenting today was the relationship between alliance and treatment type, which, you know, I'm really passionate about research on the alliance, and I felt it was an area that was neglected. So as Vera and Sibel were saying, although the alliance is usually considered a generic factor that somehow is common to all therapies, there are still reasons to suspect that it might develop differently in different types of therapy. And there are also theoretical reasons, like from a theoretical perspective, even Bordin, which is, you know, the father of the most widely used definition of the alliance as the collaboration between patient and therapist in therapy goals and tasks in the context of an emotional bond. Bordin also recognized that the characteristic of the alliance, the quality, he says, of the alliance might differ across different types of therapy. And several authors have supported this idea. And for instance, it has been argued that cognitive behavioral therapy might place more emphasis on collaboration and tasks on goals compared to psychodynamic and humanistic therapy, which might focus more on the bond. However, you know, those hypotheses have not really been tested empirically. So I was curious about that, and the majority of the research on the alliance has been focusing on the relationship between alliance and outcome. And, you know, so I thought, well, I want to check whether there is any relationship between alliance and treatment type. So in this study, I investigated whether the mean strength of the alliance, as well as the trajectory of the alliance, differ between 3 equally effective psychological treatments for adolescent depression. And based on Bordin's idea of the different components of the alliance, I also checked whether, I don't know, the bond was something that was more, that, you know, was rated higher in certain types of therapy than others, or the collaboration components of the alliance. So the data that was used for this study was taken from the IMPACT study. I'm not sure if you are familiar with that. It's a randomized controlled trial comparing cognitive behavioral therapy, short-term psychoanalytic psychotherapy, and brief psychological intervention in the treatment of adolescent depression. And the result of this randomized controlled trial was that the 3 treatments were equally effective in reducing depressive symptoms. So the alliance was measured in this randomized controlled trial at 3 time points: 6, 12, and 36 weeks since randomization. So I used the working alliance inventory, was the measure that was used to assess the alliance, which is based on Bordin definition of the alliance that I mentioned before. And this was rated by adolescents and therapists independently. So I kind of almost used 2 samples without combining exactly, you know, in relation to what Vera was saying, that, you know, the adolescent and therapist view of the alliance might differ. So I didn't combine them, but I did the same analysis on the adolescent rating of the alliance and the therapist. And anyway, what I found is that the strength of the alliance didn't really change much over time. Well, I had only 3 time points, so seriously, in terms of the trajectory of the alliance, there was not much I could say. But what I felt, it was an interesting result, it was that the alliance, the strength of the alliance, or the mean strength of the alliance, was found to be higher in short-term, in cognitive behavioral therapy, significantly higher compared to short-term psychoanalytic psychotherapy, while the treatment, as usual, the brief psychological intervention, was in the middle. And as I said, we had only 3 time points, so, you know, it was really difficult to assess the trajectory of the alliance, but there also seemed to be a relationship between the pattern of the alliance over time and treatment type, so that the alliance was increasing more in short-term psychoanalytic psychotherapy compared to the other treatment types. So while the differences were higher in the initial stage of therapy, they were reducing later on. But still, the alliance was significantly lower in short-term psychoanalytic psychotherapy compared to cognitive behavioral therapy. And in terms of assessing the different components of the alliance, unfortunately, the bond component of the alliance and the collaboration seems to go, in the same direction. We couldn't find any difference. So perhaps, this was linked to the fact that the different components of the alliance, as measured by the working alliance inventory short form, kind of are too correlated. So perhaps it's difficult to disentangle them. So yeah, I felt that this finding might suggest that the mean strength of the alliance differs between treatment type, and it would be interesting to do some further research to try to better understand what factors contribute to the differences and their relationship with outcome, perhaps.
Okay, thank you so much. So many questions come to mind, and it will be a very stimulating discussion. So now I'm going to open up the floor for discussion. Maybe I'll start with a few questions that have come to my mind when I read your very interesting papers, and then please, the participants can just raise their hands or jump in with their questions, and we'll try to reflect on these points. The one question I have for Vera is, it's a very interesting finding that the adolescent's perspective in treatment matters more than the therapist's in predicting treatment outcome. So I'll just ask why you think that is, and could there be some follow-up research that can be done to understand moderators? What kind of adolescent characteristics would be more predictive of outcome? You talk about attachment status. Are there other substantial moderators you would suggest for follow-up research?
Thank you. Yeah, I think that's a very, very interesting question about the moderators or mediators. But first, maybe to think why does the adolescent perspective matter more? Well, if you compare, at least for childhood, I think that the adolescents kind of independence increases, so their own opinion, they get a lot stronger on following their own instincts in a way. And I think that the adolescents that we have, they were very young, like 13, 14, 15. So that's exactly the moment when you start increasing more that I'm my own person and not depending on the judgment of others, and maybe also cognitively not yet that developed. So maybe the adolescents at that change also tend to make assumptions quite fast, like with their own first impressions, and it's a bit difficult to change that. So the trust kind of needs to be gained instantly, that the adolescent feels like, is this a person that I think that would understand anything from my life or not, and then kind of judge that quite quickly in a way. And maybe the therapists are more kind of positive thinking that, oh, even though the first session or even the first sessions we still haven't found kind of the common path that we will find that. So overall they might think a bit more positively and think a bit more further on than the adolescents, because we were also looking at the alliance at the baseline. So the baseline was after there was like from 1 to 3 kind of first assessment sessions before the actual therapy started. So the baseline is at that point. So they've met only few times. So that's quite a kind of the first impressions on that. And also actually the adolescents who rated the alliance better at the baseline, they had less severe symptoms. So maybe also adolescents who have less severe symptoms were a bit more optimistic about the therapy overall, and that's why maybe there could be some differences on the ratings.
Mm-hmm.
Yeah, but as said, alliance, of course, itself can also be a moderator, and we have also looked at how the alliance changes, and actually there is some research also before our research saying that the change actually in alliance is more predictive than looking at one time point. And then also the attachment, I think that's an interesting aspect. We found at least one study that had found that the adolescents who had like a poor attachment history actually had the stronger relationship, or evaluated the alliance stronger with the therapist, and that was more associated also with the outcome. So maybe there might also be some kind of reparative experiences from therapy. So that's why the attachment might also, the attachment history might be important. So what's like the overall thinking on the relations with adults and the trust that could be gained. And also the thing that I mentioned before about the treatment expectations. I think that the adolescents, like in the beginning, if you feel that okay, this person, I don't feel connected, or I don't think that this old lady can ever understand me, then you might like the expectations might go low also in the beginning, if you don't feel that I'm like that I've been understood. So I think also treatment expectations could be an interesting moderator in the outcome alliance association.
No, absolutely. And I mean, from child work, I've done alliance studies in child work. The reason I asked about moderators is in child work, children with externalizing problems, their ratings of alliance matter more than children with internalizing problems. And it probably has to do again with attachment status and treatment expectations. With children who have externalizing problems, it's much harder to establish therapeutic alliance. They're more defiant, oppositional, they have less treatment expectations. But once it is established, it's more predictive of outcome. So I wondered also in your study, a subgroup analysis would be extremely interesting to understand for which adolescents, attachment or other types of symptoms, for which type of adolescents.
Yeah, that's an interesting aspect. Yeah, and we could actually have a look on that, because one of the predictors of treatment outcome that we have is the type of symptoms. Is it internalizing or externalizing? That is actually something that we could have a look on the association with alliance also.
Would be so excited to hear your results. Tamara, you have a question?
Yes, thank you. And it just came to my mind when listening, Vera, and probably it has to do a lot with Antonella's research as well, because I'm thinking about, and I wonder whether that was studied or maybe you had in mind, what happens or what happened with the therapist's characteristics. Not only the type of treatment, but where do therapist characteristics come in play? Was there any prediction done in that way? And if you could possibly hypothesize, what do you think, what would be interesting to conclude?
Yeah, unfortunately, we didn't have any kind of baseline characteristics on the therapist. We know very little on the therapist that we had in the study. We actually had 47 therapists overall in the study, because this is a naturalistic study. So there was very different types of therapy. But I do think that would be very interesting to also see the relations and perhaps like empathy and maybe the ability to attune to patients' emotions would be something very important for the adolescent alliance, and also being genuine. That's something that I'm thinking very often with adolescents, that they do kind of notice if you're trying to fake it or take like to professional position or something like that. So being like very open and genuine, that could also be something interesting.
And if I can add something, unfortunately, we also didn't have any therapy characteristics. So what we did when we looked at the alliance across the different treatment types, it was try to control for the therapist effect. So, so we were able to control for that in the analysis, but it would be very interesting to check if there are some, characteristic of the therapist that, there are more studies on the alliance going on using the impact sample. And so, like anecdotally, I can say that there have been adolescents that have dropped out just because they thought that their therapist was very old, So, there are some characteristics, I'm sure they play a role, but unfortunately in this specific study, there is not something about therapists that I could say.
But did you have that in the impact study? So would you have the therapist characteristics also in the impact?
No, we don't have. Unfortunately, we collected very little data about the therapists. So now there is one of my master students that's looking at what adolescent baseline characteristic might predict the alliance, because we expect that this is the case, but we can't do the same from the therapist perspective because we haven't collected data about the therapists.
Yeah, the same for us, that we can only use the patient characteristics as a predictor of the alliance, but not the therapist one. So this is also one thing that always, when you look back at like, oh, why didn't I do that when I started the study? This is one thing that I've been thinking, like during these years, that why don't we know anything actually about the therapist? Very, very little. So unfortunately.
One thing that occurs to me, I'll come to you. This is also tying into both of what you said, Vera. The finding you have about the discrepancy between therapist and child, therapist and adolescent being predictive of treatment dropout. I thought one characteristic that could be assessed in both of your studies is therapist reflective function. And I wonder if that can be done through session transcripts. Do you have any recorded data, Antonella? Maybe you have some. So there is a rating system that assesses therapist reflective function through session transcripts. Even if you don't have baseline data, that could be an interesting predictor in terms of differentiating therapies. To give you more coding burden.
Yeah, unfortunately, at least we don't have any session recordings or transcripts or anything like this because it was quite small naturalistic study, and the therapies were actually, I won't go deep into that but outsourced from the hospital, so both from private practitioners and yeah, so there were many things that you couldn't do as this wasn't done in a research center or an RCT setting or something like that. So
we actually do have the audio recording of therapy session, not for all of them, for some of them. But I think what's more important, perhaps, or equally important, is that we also have qualitative interview with both adolescent and therapists. So, I actually, following this study, I did a single case study on where I listened to all the therapy session and what the adolescent and the therapist said at the end of therapy, which helped me a little bit more understanding perhaps the why. But, as I said, to be able to do things so deeply and listen to all therapy session and so forth, then you need to do a single case, and the result of a single case cannot be generalized to all of them. So we need to accumulate more single cases, perhaps.
Mm-hmm. Camelia, you had a question.
Yes, that was again a more workload to the people who has already done a wonderful job. But as Antonella is at the Anna Freud Center, at your master student is doing a research on adolescent characteristics, I thought of one obvious moderator perhaps, which is the epistemic trust, because in both of your studies, you've mentioned that this is a basic characteristics, and for a couple of years now, we have the opportunity to measure that. So probably that would be one direction to look for when we plan with future studies.
Yeah, absolutely. It was one of the characteristics that emerged from the single case study that actually, according to the adolescent perspective, what helped in the relationship was the development of trust. So yeah, that makes a lot of sense. Thank you.
Yeah.
No, just on that, I was wondering whether retrospectively, does anyone feel that can be measured, that one can qualitatively look at a transcript, for instance, and pick out a reliable way of measuring epistemic trust? I know we have Chloe Campbell's measure going forwards, but has anyone done anything looking at extracting whether epistemic trust was, I mean, Vera, you mentioned some of the kind of key qualities like warmth and interest as being things that the adolescents valued. Yeah, it sounds like they were leaping out.
Yeah, I was actually wondering the same, because as I said, from one of the single cases emerged trust as something that the adolescent valued. And I was wondering whether there was a measure from the transcript of the session about epistemic trust, but I'm not sure whether there is, but you know, based on the result of this other study, according to the adolescent, because since the adolescent specifically talked about trust, then the interviewer was asking, according to him, you know, what helped develop the trust. And the single case was in short-term psychoanalytic psychotherapy, and said that what helped the adolescent to trust the therapist, it was the sense that the therapy genuinely cared, which is related to what Vera said. And I was really interested, was willing to help, and was not judgmental. And also the reliability of the setting. Didn't mention the setting, but said the fact that the session were always at the same time every week, you know, so that helped to create that sense of trust, that there was something reliable there. But, you know, there was something about being genuinely interested in them.
Mm-hmm.
This is, you know, what was reported by one adolescent, but yeah.
Mm-hmm.
Yeah, that is very interesting. I haven't looked at the data at all, but in the five-year follow-up, so all adolescents, if they went maximum 3 years to therapy, so this was like 2 years, at least 2 years after therapy, we sent them actually kind of structured questionnaire based on the interview that I think you were using. I received it from Nick from the impact study, and then kind of fusioned it with few other interviews. We tried to make like a questionnaire on the adolescent's experience on therapy, and there are some questions that we are also asking, like, what do you remember from therapy? What was the thing that helped you, if you felt that the therapy was helpful? So there might be some things related to that, but of course it's very retrospectively, and we only have 32 of the 58 adolescents answered us later on. But yeah, that's some data that I haven't touched very much yet, but I'm very anxious or very excited to see what's in that data also. What do adolescents, when they are already kind of young adults, what do they think? What was the things that helped them in therapy? So.
I don't know if this Gary, I think our next, to advertise, our next CAFTR Journal Club will be on how to measure epistemic trust, which is, you know, an issue in itself, but something we have tried, similar to what you've said, Antonella, a single case study of one of my master's students who's here, and maybe she would like to say something on that. Is in long-term psychoanalytic therapy, we looked at associations between mentalization adherence and alliance. And in the mentalization adherence scale with children, there are 6 qualities of therapist stance that match with epistemic trust, like genuineness, curiosity, staying with the developmental level of the child. And we found that those were predictive of therapeutic alliance in a good we compared Dilara here. Maybe she would like to say
it's me. Hello, everyone.
Yes.
Yes, I was thinking about my work also. It's still a work in progress, but we kind of try to understand these therapist characteristics that affect the alliance. And in these two children cases, we looked at like therapist adherence to mentalization and the relationship with therapeutic alliance. And at the end, apparently, like this adherence predicts the alliance. It results in a stronger alliance with the child, and especially the stance, so which involves like things like the therapist being authentic, playful, and genuine, those type of things. So like they can be considered as some therapist characteristics that lead to a stronger relationship.
That's brilliant. And tell us, but this is ratings of videos or audios of sessions.
Yes, we have all recordings of the sessions in our center, so it's 2 child cases. Like, and the thing we did is one case is with a better outcome, and one case resulted in a kind of worse outcome. And we like coded all the sessions of all the therapy process actually with the child. And like we did a time series analysis. Like it's still a work in progress. I'm still working on it. But this result is interesting. Yeah,
absolutely. Gosh, can I be in touch in relation to, because I'm trying to design my study in relation to measuring, and I hadn't quite appreciated that one way is through, as you're pointing to the adherence scale, that perhaps if we haven't, my worry was we have a study on the way and we haven't collected epistemic trust questionnaires, I don't think, anyway. We haven't measured that, but we were measuring adherence. And we will be having qualitative interviews afterwards. That could be really helpful. Yeah, thank you.
Thank you.
Brilliant.
Okay, so going back to your studies, Antonella, I had a question to you based on your work. So in psychodynamic psychotherapy, you find that alliance is significantly lower. Mean alliance, the strength of alliance is lower than in other treatments. So I'll just ask, be the devil's advocate, what does that say to us in terms of treatment indications? Would we say that psychodynamic psychotherapy is not indicated for certain patient profiles? And also, do you think this finding strength of alliance, measuring it in psychodynamic psychotherapy, does that really reflect the alliance characteristics that takes place in treatment, or should we measure it differently in psychodynamic psychotherapy?
Yeah, so there's quite a few questions in there.
I know, I just bombed it off. Sorry.
No, but it's quite interesting because, well, you know, in terms of my supervisor kind of expected that result. While I did not, for some reason, I was expecting that STPP, and there are no hypotheses in my study, as you can see, because there were controversial discussion about what we could hypothesize, and you know there was no theoretical reason to be thinking, you know, there could be reason in any direction. So you know we had to be surprised by the data. And no, I don't think that the fact that the alliance was lower in short-term psychoanalytic psychotherapy might suggest that, you know, the treatment is not indicated, because the reality is, and the interesting fact is that the 3 treatments were equally effective. So, you know, the alliance was different, but, you know, that meant that even if in STPP the alliance was rated lower, the treatment was still effective. So they might be doing something which, measured by the Working Alliance inventory results in a lower strength of the alliance. But with the second generation of alliance research, thinking about the alliance has a dynamic component, of the therapeutic relationship, so something that can change. Somehow the Working Alliance inventory, the way we measure that, it's kind of taking a picture of, one moment of the alliance. So perhaps that, it's a reductionist way of, measuring the alliance, especially because it was not even at the end of each session. So it could be that, lower rating of the alliance are due to the fact that the measure that was used is not really in line with the way the alliance is conceptualized and developed in short-term psychoanalytic psychotherapy. In fact, in the treatment manual, there was no mention of boarding definition, but more of psychodynamic definition like Luborsky. And there is no mention of the discussion on agreement on therapy tasks and goals, which is what's mainly measured by the alliance. So I would say it could be different things. It could be that the alliance was slow because there were ruptures in the alliance, and perhaps later they were resolved, but we weren't able to measure that. And I'm saying that also because in the single case, I purposely selected a case that showed very low alliance at the beginning of therapy and higher alliance later on, just to try to understand what had happened and had good outcome. So based on this study, all we could say is that according to the Working Alliance inventory, so boarding definition of the alliance is rated lower in short-term psychoanalytic psychotherapy, but this does not necessarily compromise outcome. What does that mean? I think that I might need to do some further research. It could be because the definition of the alliance is not really in line with the way it's talked about and used in this type of therapy. Or it could be that, one of the characteristics of short-term psychoanalytic psychotherapy is to allow negative feelings to enter the relationship by what is called the negative transference. And so working on that could be something frustrating for the adolescent, which could cause some rupture and then result in lower ratings of the alliance. But hopefully, if those ruptures are resolved, that could still lead to good outcome, which perhaps could explain why in short-term psychoanalytic psychotherapy, the alliance slightly increased more over time compared to the other treatment types. But, in this specific study, all I could say is that it didn't compromise outcome, so perhaps it was not that bad. In another study, I linked that with outcome, and it was interesting. I actually looked at the relationship between alliance and outcome in the impact study, and what we found was that there was a relationship and was moderated by treatment type, which meant that the early alliance outcome relationship was stronger in cognitive behavioral therapy compared to short-term psychoanalytic psychotherapy. So it makes sense that perhaps this definition of the alliance leads to better outcome in cognitive behavioral therapy and less so in short-term psychoanalytic psychotherapy. But they might be doing something that we might not be able to measure with the Working Alliance inventory that still led to good outcomes.
Yeah, but one thing that comes up today is questioning whether Borden's definition of Working Alliance and the Working Alliance inventory is the best measure in short-term psychodynamic therapy, and perhaps epistemic trust is a better measure, or some measure of transference counter-transference.
Yeah.
That is true, and also thinking about that also, Antonella, you found in your study, but there is also some other studies that suggest that the boarding idea that there's different dimensions in the alliance that doesn't fit adolescents. That adolescent alliance is more like one-dimensional, so that's why we actually didn't even look at the subscales in the Working Alliance inventory, because the recent research on the adolescent alliance is telling that's not useful. So there is something, I don't know if it's like overall in the concept of alliance that is different for adolescents perhaps than for adults or for children, or is it just the working alliance inventory that it doesn't really fit as well with adolescents than perhaps with adults?
Same thing with children, Vera. The factors don't, it's all one factor also with children. The factors don't diverge. Mm-hmm.
Yes, that was again something I would mention, because as of an outcome of this Treat Me network, an action we are planning, and we are doing a systematic review on the alliance measures for adolescents and young people, and it's a huge mess because actually there is no instruments that are particularly adapted or verified for that age group, which makes our work incredibly difficult.
There is a question in chat or a comment from Jan. I hope I'm pronouncing it right. So he can't put on his microphone, but I would like to read what he said. So he's gonna have a presentation at Adolescent Psychotherapy, and his topic is what adolescents need, want, and are looking for when they come to treatment in adolescent psychiatry, or something like that. So if you have some good research results to hint, please email me. Antonella, some of your qualitative results are actually very pertinent for this.
Yeah, that's what I was thinking. You know, this links back to the idea of whether we do actually have good enough measure, because I'm not sure whether any of them do include some, you know, characteristics of the alliance that have been suggested by the young people as being relevant to them, rather than you know, creating a definition and then adapting that into a measure and fitting it with young people. I think what would be needed is perhaps you know, some qualitative study to check in with adolescent or young people about what they think are the essential characteristic of a good relationship and an alliance. But yeah, we're trying to do that with single cases or analyzing the post-therapy qualitative interviews.
And we might also try to have a look on something on the treatment expectations. We had a measure on that, not very good for adolescents, but still. And then also like the qualitative data that we have from the 5-year follow-up might answer to some of the questions Jan has, but we're still not yet there. So.
Rose, you have a question?
Yeah, it's probably a very obvious brief point, but I think something to always keep in mind is just how honest adolescents or anyone is going to be when they're filling in a questionnaire about something like alliance. And from doing sort of PPI work, teenagers that I've spoken with have said that they never tell the truth on measures like that, because particularly after something like a year of therapy, they just think it's not nice to the therapist if they say they don't find the alliance to be very good. So I guess in a research study, you can kind of account for that by ensuring that the young person knows that what they say won't be shared with their therapist and things like that. But I was just mindful of what Vera was saying at the beginning, sort of in a practical clinical context, if you want to be using an alliance measure to identify early if it's low, or identify early if there's a discrepancy between the patients and the clinician, that would involve sharing that information with the clinician in a way that the young person might, if they knew that, they might not be honest about it. So I think a real practical challenge outside of research is how do you get young people to feel able to share that? And I wonder whether that differs across different kinds of therapy as well, because if in a more sort of psychoanalytic therapy, there was already an honest discussion of the relationship and how it was going and identifying difficult emotions, maybe even in that context, the young person might feel more able to say that because it had already been sort of broached as a topic. I don't know. That was just something that came to mind.
Yeah, I think it's a very valid point, Rose, and it's one of the main critiques of the measure on the alliance, because what has been found is that actually usually the strength of the alliance, the mean is quite high when rated by young people. So there is this idea that there is some bias in that, also because current measure of the alliance measure mainly agreement or collaboration, and there is no mention whatsoever of any disagreement or rupture, even resolution of such rupture. So those aspects gets completely neglected or not measured at all by the current measure. There are no question about disagreement, so it's quite difficult to capture them with the current measures.
Mm-hmm. We need to develop new measures, it seems.
Yeah, more work for Camellia trying to find or make some recommendations on what measures to use or how to measure the alliance with adolescents.
Mm-hmm. Or borrow from related fields like mentalization, epistemic trough, mentalization adherence scale, which also addresses rupture repairs. So maybe there is some work to be done in terms of incorporating other ideas that fit better the type of treatment that we're doing. We have just a few minutes left. Maybe we can take one more question if there's a question or comments. Anything you wanted to say, Vera and Antonella?
I just want to thank everybody for the good discussion and the very relevant points that you're raising, and also kind of make Informants and new ideas what we could have done or what we should have been doing, or what we can do in the future now when we establish new research, like what to keep in mind when you think about alliance, especially with adolescents. That's always a bit tricky part, that you can't really use the knowledge that you have from the adult psychotherapy, or the same measures might not fit, and then you think like, what's the parents' role, what's the role of teachers and all that. So yeah, there is quite a lot of things that still need more research.
Gary, you had something to say?
Just to say, I thought the two papers were excellent choices, and just very grateful that we're having this opportunity. I think it's excellent, and thank you for organising it. Yeah. Yeah. Thank you.
Yeah, I also wanted to say something similar. It's such a pleasure to get to learn more about, what other people working in a field that, I'm really passionate about are doing, and to learn from each other. So I'll be happy to join the next, and yeah. And it'll be great if we could keep in touch in terms of sharing, because there are some common challenges, like how do we measure epistemic trust, and if we can discuss these things, perhaps in the future we'll be able to measure them better.
I could say something.
Please.
I'm a body psychotherapist, so I'm just maybe bringing the point of view of the body also in these studies, and the body-mind connection, and how the therapist also a whole human being, not just like what is like written in the transcripts. So maybe that point of view might help in the future studies a little bit, because like in the communication, the words are just some percentage, some percents of the whole communication and contact. So it's good to look at under the tip of the iceberg sometimes. And then the whole bodily being is also very important, like how the therapist is in contact, in interaction, and the whole being. So in some instances, they are also like emphasizing the need to look at the like the personality of the therapist, not just the method. So when maybe those are looked into more in detail, not just looking at the transcripts like what somebody has said, but like how people interact and how they are in contact. And not to forget, for example, mirror neurons, like how you're like in like smaller details tuning in to the patient. So those are very important. Just the whole being of the therapist as well, how they are interacting with their whole being, not just like on the mental level and words, but then as a whole being, just bringing that into mind. Like you mentioned, like all these things that are important in the connection, like being interested and cared, and then wanting to help, curiosity, mentalization, being authentic, playful, and genuine, and so on. They're also like whole bodily phenomena as well. So how those are present in the interaction and the connection, that might be something that could be very crucial also, like in the future, since the body-mind connection is coming more and more. The more they research even the brains, the more they are having emphasis on the whole human being and the body-mind connection as well. So that could bring a lot also to the connection between the therapist and the patient.
Absolutely, and Gary also shared the concept of embodied mentalizing. I completely agree. The coordination, entrainment, the bodily tuning in is a major part of Alliance, especially with younger populations. So thank you so much for bringing in that aspect.
Yeah,
Yes,
it's a very good reminder that does the alliance also show in the how are the patient and the therapist connected in the treatment. So sometimes maybe that is as somebody raised earlier, that the adolescents might not be very honest when they've asked on something, but then they might express it with the body if they're not feeling very comfortable with the therapist, or they feel that the therapist really does not understand what I'm talking about at all. So that might be something that they say something different than the body expresses. So that's very interesting. Yeah.
So a lot to think about. So many questions, more questions to ponder upon. I hope we'll be able to do that in our next meetings. Today, I would really like to thank Antonella and Vera for initiating this first discussion club. Thank you for sharing your work so generously. This was a great discussion. So many stimulating ideas, so many thoughts for future discussion, so many research ideas. So I'm grateful to Antonella, Vera, and to everyone who's been here for this very fruitful space. And we hope to continue it in the future. So thank you so much.
Thank you very much.
Thank you for organizing this.
Thank you, Sibel. Yes.
Thank you. Please write to me if you are interested in presenting or other topics that you'd like to hear about, and we would be happy to organize them.
Sibel, did you say the next one will be Epistemic Trust? Did you say? Yeah, fantastic.
I did. It's sealed.
Thank you.
I did, yes.
Thank you very much.
Yes,
Thank
thanks
you.
again. Bye-bye.
Good evening, good night. Bye-bye.